Dr. Lederman to hit the cancer. For a free booklet DVD called 212 Choices, 212 Choices for a fresh second opinion. Most insurances, Medicare, Medicaid, accepted. Not only super convenient, super. Broadway and 38th in Manhattan. To hit your cancer, see Dr. Lederman, 212 Choices.
With Dr. Lederman, the best prostate cancer treatment is custom tailored for you. Each man with prostate cancer is unique and seeks the best results based upon PSA, Gleason score, and stage. That's why Dr. Lederman's custom tailored prostate cancer treatment is most logical. Not every man should get the same treatment. Dr. Lederman's custom prostate cancer treatment is all outpatient. Our goals are your best results, avoiding radical surgery, maintaining your sexual and urinary function, and your life. Most insurances, Medicare, Medicaid accepted. Call Dr. Lederman at 212 Choices, 212 Choices for a fresh second opinion and free booklet DVD. Not only super convenient, super in Manhattan, 38th and Broadway. To hit the cancer, call Dr. Lederman, 212 Choices. Cherish your life. Custom prostate cancer treatment with Dr. Lederman, 212 Choices.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212 Choices for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hey, we're back, and thanks, John, for that phone call. If you do have questions, you want to talk on the radio, just call us at 1-800-321-0710. 1-800-321-0710. We're live at the WOR Studios. We had a call this week from a woman, 53 years old, with a uterine sarcoma. It's a sarcoma is a cancer of the connective tissues of the body, which we don't think about too much. But for those affected, we think about it a lot. So the uterus is where the baby grows. We talked about another woman who had a fallopian tube cancer, the cancer from the tube connecting the ovary to the uterus. And now this woman had a cancer of the muscle of the uterus. And the muscle of the uterus is used to contract and expel the baby when the baby's 9 months old, push it out to life. So sometimes that muscle tries to take the woman's life, and in that case, this woman called, she had leiomyosarcoma, which is a form of sarcoma, soft tissue cancer of the muscle, and like many sarcomas, they often spread to the lungs. So she's been on chemotherapy. Chemotherapy is not working. Her doctor told her, well, it would have grown faster, but it's already growing too fast. It's growing on chemo. If chemo works, it would be shrinking. So it's another teaching point. If the cancer is growing or if it's not tolerated, it's time to call us. So this woman called us. There's 5 metastases. She's coming in. We have a huge experience treating sarcomas, and the reason is that often chemotherapy, just like on the caller with John, chemotherapy resists the cancer so that the cancer keeps growing. So in this case, sarcoma, we have excellent results, often in the primary site, whether it's the leg or the arm or the pelvis or the abdominal area, or in the lungs where sarcomas often spread. You should give us a call if you wish, and we can talk about other options that may be better tolerated, more effective, and hopefully make you healthier and happier. And speaking about cancers in the lung, there's a new report that says if people are staged, and we often talk about staging. Staging means what is the extent of the cancer? Where is the cancer? So in a report published in a significant medical journal, the Journal of Nuclear Medicine, March, showed that routine preoperative PET scans reduces unnecessary surgery for lung cancer. The doctors reviewed about 1,000 cases from Seattle. they found that there were unnecessary operations that occurred and could be reduced by 50% if people had imaging. Now, some people come to me and say, well, why didn't my doctor order imaging? Well, perhaps they just wanted to do the surgery. I don't know. I don't know what's in someone else's head, but it would make sense to know, where is my cancer before someone goes in to cut it out? How can you know what to cut out if you don't have the roadmap to know where the cancer is? It just doesn't make sense. And if you're operating on the lung and the cancer's already traveled to, let's say, the liver or some other place, why would you want to waste your time and energy and money on operating on the lung when the cancer's already traveled? Wouldn't it make more sense to give treatment to the whole area of cancer, radiosurgery or something else? Wouldn't it make sense? So most commonly, best staging for most cancers will include PET scans. And if you do great center scans, we use several centers. They're not related to us, but we've tried to identify the best centers. They'll often even use intravenous contrast with the PET scan. So it's almost like a 3-for-1 scan rather than a 2-for-1 scan. So you can actually see more of the extent of cancer than you otherwise would. And the doctors wrote in this report that 30% of the surgeries were unnecessary. There were 976 surgeries and 296, almost 300 cases out of 976 were unnecessary. The patients should have had staging and no surgery. So isn't that what we're here for? Trying to get you better health, better information, try to make logical choices for you, your loved ones, your friends. So here's a case. When you get proper staging, 300 out of the 900-plus people could have avoided that surgery and all the complications of the surgery. We have a caller. Vinny's on the line from Belmore. Good morning, Vinny. How are you today?
Hi, Dr. Lederman. How are you today?
Fine, thank God. How are you?
I'm fine.
Right.
I'm fine. I just had a few questions because I have a lot of history of prostate cancer in my family.
Sorry to hear that.
And thank you. My dad, about 20 years ago, was diagnosed with prostate cancer. Thank God he had the PSA test, and he was able to find out. Mm-hmm. And he had opted at the time to remove the prostate.
Okay.
And thank God he's still with us today. You know,
great.
He's okay. Now, more recently, about 3 years ago, my brother was found with prostate cancer. Mm-hmm. Now, he went to one of the big hospitals here in New York, and they told him that he ended up getting it removed as well. They told him that the seed procedure, if he did that, if it didn't work, the problem was if he ever decided to get it removed, that the seeds would deteriorate the prostate. And I was wondering what your thoughts were on that. I know your whole procedure is different, and I like what you do, but does that make any sense? If the
Well, let's
seed
talk
doesn't
about
work?
it. Do you remember what your father or your brother's PSA was and Gleason score?
I don't know what they were, but I know they were up there, and I know that on my brother, they, of course, once they find the high PSA, they do the biopsy where they...
Do you know how high his PSA was? Was it 4, 10, 20, or...
No, I don't know the number. I just know it was up there, and I know that when they did the biopsy, they found
All right.
positive.
Let's try to answer your question and try to do it in a logical way.
Okay.
We do have a booklet, and I'd be happy to send you this booklet about prostate cancer. It actually looks at the data. So let's just say you go to the the chief of urology at one of the most famous cancer hospitals around, and I think we know what we're talking about there. And if he has a PSA, let's say between 4 and 10, if that man has surgery, there's a 76% chance he'll be cancer-free at 5 years. If that patient came to us and had brachytherapy, which is a seed implantation, and treatment in the stereotactic frame, our treatment, the success rate would be 90%. So if you're going to Atlantic City and putting all your money on a casino, would you put it on the 76% success or the 90% success? And I think most of us would put it on the 90% success. The problem is that often surgeons, unfortunately, let people believe falsely that if they remove the prostate, they'll be home free. And there's data, and again, I'll show you this data if you come in. We're preparing a new prostate cancer booklet, which is going to include this new information, but of men who go through open surgery or robotic surgery, only 20% or less keep normal control of their urine with open surgery, 13% with robotic surgery. So actually, robotic surgery seems to have more complications. Only 13% of men with robotic surgery have normal urination. And with sexual function, and this is a report from Harvard Medical School, it's published in the Journal of Clinical Oncology. I can give you the reference. It was volume 30, page 513. People who had open surgery, only 2.9% of men kept normal sexual function. And if you had robotic surgery, and again, most people are led to believe if it's robotic, you're going to be better off. Actually, only 2.3% of men had normal sexual function after robotic surgery. So, number one, the success rate of surgery is much less than with us, and the complication rate is much more. Most of our men keep urinary control. That's almost never an issue. And the majority of our men keep sexual function. Now, you ask another question, and that is, what about secondary treatment? What's better for you, surgery or radiation? Well, it's true that if you have surgery, you can have radiation. That's true. But the problem is the secondary radiation. If you give radiation second line when the surgery fails, number one, most men are already peeing in their pants. Most men are already impotent. And the likelihood of success as second-line therapy is much less. And if you look at the death rate from people who have surgery versus the death rate of people who have radiation, the success rate is much higher with radiation first, not radiation second. So the surgeons are kind of using a circuitous argument to make you think that doing surgery first will allow you, you can have radiation down the road if you want.
Right.
Yeah, but that radiation doesn't work very well because the surgeon has spread the crumbs of the cancer. And once they spread the crumbs of the cancer, the chance of successful second treatment falls precipitously. So from my point of view, if you look at the data, and we give the data to every man, I think we're the only center that treats prostate cancer that gives patients the data before they get treated. And it's our data versus the most famous hospitals in New York and Boston and Philadelphia and Baltimore and Texas and California. And it compares it all so you can actually see your chance of success. Because again, once the cancer comes back after surgery, for most people, they have a small chance of being cured. Yeah, you can be treated, but there's a difference between treatment and cure. And that's what people forget about or they get confused about, or maybe the surgeon even wants you to be confused about it. Treatment is not necessarily cure.
Can I interrupt you for a second?
Anything, not interruption. I'm here for you.
Okay. Has the procedure of the seeds changed since it started?
Of course.
I've been hearing about it for many years now.
Of course. Well, it started first in 1986.
Right.
So in those days, there wasn't good imaging of the prostate. There wasn't operating room computers. It was based on everything's based on the experience of the physician. But today, when we go in the operating room, we have computers to help guide us. We have imaging to help guide us. And so the quality has increased dramatically. And I'll also tell you one other thing, in kind of a parallel answer to that. If you look at different facilities have different results. For example, if you look at our results versus a very big hospital in Manhattan for the same prostate cancer, let's say intermediate risk, which means either the PSA is more than 10 or the Gleason score is more than 6. If you had seed and radiation there, their success rate is 65%. With us, the same group of men, 87%. It's a 34% difference. So just the person who does it is different. The facility that does it is different. And sometimes it's hard to make people understand that each center has its own reputation, its own style, its own treatment.